Hello, everybody. My name is Robert Landewe. I'm a rheumatologist working in the Netherlands, and it's a pleasure to speak to you about overdiagnosis in rheumatology. I'll share with you potential conflicts of interest, a couple potential conflicts of interest that you can see here. What is especially important here is that I'm the current chair of the Committee of Quality of Care for EULAR. And I will talk this afternoon or this evening to you about an elephant in the room. And I'll explain you in a moment what I mean by that. If you look it up in the dictionary, you will see that we are talking about an elephant in the room when you mean that there is an obvious problem or an uncomfortable situation that people prefer not to talk about. And that uncomfortable situation is the situation of overdiagnosis. And we as doctors don't like to talk about overdiagnosis because essentially it means that we have made a mistake. And when we're talking about overdiagnosis, it's obvious that it is easy to overtreat patients for the obvious reason that if the diagnosis should not have been established, you shouldn't have started a treatment. Overdiagnosis, by definition, is the diagnosis of a medical condition that would never have caused any symptoms or problems to the patient. And this kind of diagnosis can be harmful if it leads to psychological stress and unnecessary treatment. And of note, overdiagnosis, with that I mean a right diagnosis, not a wrong diagnosis, because that is misdiagnosis. So please keep that in mind for the remainder of the presentation. Overdiagnosis is a term that is coined by cancer screening. In the field of cancer screening, screening tests are done in order to discover illnesses before they cause symptoms. That is what the dictionary says. And if you do screening for cancer, there's obviously a couple of hidden assumptions underlying screening. First, it means that every early case will get the feared outcome. So if you detect cancer early, you implicitly assume that this cancer, if not treated, will lead to a worrisome or unfavorable outcome. Early also implies a better prognosis, obviously, that if you make a diagnosis earlier, that it is better for the patient. And you also imply that if you treat early, that is implicitly safe. Early is always better is actually a little bit of a hype, especially in the cancer screening industry, so to say. It's always better to do it early than to wait a while. And I will introduce to you the issue of breast cancer screening in order to prevent early mortality. Nothing new for you, we do it in many countries in the world, and we see that essentially breast cancer screening, when introduced by the end of the 1980s in the previous century, in those that were eligible to screening, and that were those in the age group between 50 and 64, that leads to an enormous, a tremendous increase in the incidence of breast cancer. You see that over here. It was already anticipated that screening would be introduced, and even by then, that led to an increase in the incidence. You may say, well, that is awfully good that that happens. It actually should happen. But that should only happen if this early detection of breast cancer would lead to a decrease in mortality later on with a lag time of approximately 5 to 10 years. And ladies and gentlemen, obviously that is what has not happened in the past. So although the incidence of breast cancer increased over time, that did not lead to a decrease in breast cancer related mortality or in overall mortality. So it actually it tells us that who's looking for disease shall ultimately find disease. This is called overdiagnosis. In fact, there are patients in whom the outcome that is feared and that should be prevented actually isn't prevented. And it is estimated currently that when we are talking about breast cancer screening, that 1 out of every 3 cases with breast cancer is a case of overdiagnosis. Obviously, and unfortunately, we do not know upfront which of these 3 cases is the case of overdiagnosis. It leads to more than overdiagnosis alone. It also leads to false positive findings, which is essentially something different. False positive findings are findings that ultimately turn out not to be cancer cases, unlike overdiagnosis, where cancer is indeed confirmed by pathological anatomical diagnosis. False positive findings are far more frequent. They occur 8 to 10 times as many as true positive diagnosis of breast cancer. There are many other forms of screening: cancer screening, prostate cancer screening, lung cancer screening, but also cardiovascular risk screening for actually any form of screening. You may argue, why bother about this? Because early detection essentially is good. That is the medical adage, the medical axioma, so to say. Well, there is 2 reasons to bother, and I will discuss them briefly with you. The first is that by introducing screening, we cause a sort of increase of incidence of milder cases, not the severe cases, but the mild cases. And obviously, second point, there is less yield per case. I will explain to you later why that is the case. There are many reasons to bother about diagnosis by screening, by cancer screening, that are actually, well, for which you should bother. One of the most important is anxiety. Sickness, fear, work disability, stress, and so on. It is all the consequence of a diagnosis of cancer. And if that cancer is a case of overdiagnosis, so a diagnosis that essentially shouldn't have been established, then obviously it is an important reason for bad outcomes, although not the bad outcomes that you expect in the context of cancer. There's loss of quality of life by anxiety, and it is a good principle that there is some sort of balance between the gain by making a diagnosis on the one hand, namely that you could prevent early mortality, for instance, or a lot of morbidity, and on the other hand, the loss caused by anxiety, depression, and so on. When that is not in balance anymore, it ultimately leads to loss of quality of life, which should be prevented. And if you don't believe that, overdiagnosis and overtreatment are a serious reason for a lot of cost in the medical industry, in the society. Let's turn toward rheumatology, because that is what we are currently today talking about. There is a lot of risk of overdiagnosis and overtreatment in the field of rheumatology. And the first is that the definition of most of our diseases are not well established, but more or less moving targets. They are due to, or they are based at least on criteria, on classification criteria. And sometimes these classification criteria are subject to change over time, especially when we want to make diagnosis earlier. And that is because we have to deal with the early is always better paradigm that I already talked about. You also in rheumatology, we often think that we should make diagnosis as early as possible. And then there is the issue, especially in rheumatology, that we see many mild cases, not only the cases that we find in randomized controlled trials, which are most of the time severe cases, but very many mild cases in common clinical practice that we know of, that they will not always become severe cases, even not if they remain untreated. And then the last factor of importance here is that we live in a world with expensive drugs competition. For diseases like rheumatoid arthritis or axial spondyloarthritis, we have up to 20 expensive drugs, and the companies that produce these drugs are in a heavy competition with each other in order to get some part of the market share. That is also relevant. So here is a summary of what I just discussed. Actually, when we start with making a diagnosis earlier in rheumatology, it will lead to an increased incidence of milder cases. And when we, alongside those increased incidence of milder cases, realize that we have an early treatment paradigm in which we have to treat those patients also, or even worse, that we have an intensive treatment paradigm, talking about treat to target or early intensive treatment, so the intensive treatment paradigm, those situations together, those causes together, will lead to an absolute and relative overtreatment. And we have many potential examples in rheumatology. You will be aware of the osteopenia osteoporosis discussion, in which the diagnosis of osteoporosis is heavily stretched in order to increase the treatment, the early treatment of patients with already osteopenia. You will be aware of early undifferentiated arthritis before you can make a real diagnosis of rheumatoid arthritis, or even of clinically suspect arthralgia, which means joint pain in the absence of real demonstrable clinical synovitis. And then obviously we have non-radiographic axial spondyloarthritis. What, ladies and gentlemen, is a non-radiographic axial spondyloarthritis patient? Well, here is an example of what we meant in the early days with the classification criteria for axial spondyloarthritis with a real non-radiographic patient. A young man was developed inflammatory back pain and knee arthritis at the age of 22, which is only 2 years ago, as a father with Bechterev's disease, has impaired lumbar mobility upon clinical examination, has a positive HLA-B27 test, and has a pelvic MRI that is more or less as follows. And you see here, left below, the MRI of this patient with classical bone marrow edema, both sides of the pelvis, in the presence of still normal X-rays. More than 10 years ago, we thought, well, there's many of those patients around and we have to diagnose them earlier in order to give them a better chance for a better outcome. This is what we call in German the Gestalt of non-radiographic axial spondyloarthritis. And that was what we had in mind when we developed the non-radiographic axial spondyloarthritis criteria in 2009, published, and among the most frequently cited articles in the rheumatological literature nowadays. These criteria, these classification criteria, are characterized by inclusivity rather than exclusivity. They are supposed to include all those patients that may have early spondyloarthritis, and they are not as specific as, for instance, the previous modified New York criteria for ankylosing spondylitis were. And there is actually 3 important principles of this new entity. The first is that in the criteria, positive imaging, especially MRI, that feature is dominant, very important. The second is that you should be able to make a diagnosis of non-radiographic without positive imaging. It was deliberately thought of in those days that there were many patients around that would have this inflammatory condition, but may not have a positive MRI or a positive pelvic X-ray. And then the third was that patient-reported signs and symptoms, rather than objective signs of inflammations, were highly valued. 3 reasons for inclusivity of the classification criteria. And Big Pharma has realized this very well, that there is a large and unused potential, unexploited potential of patients with potentially non-radiographic axial SPA that potentially could be helped with expensive biological DMARDs. And you see this reflected by the fact that in all those checklists of drug prices and drug price times volume, so what is the yield of a particular drug, that in the top 10 were always at least 5 drugs used for rheumatological conditions, so providing a lot of extra profit for these companies. Axial spondyloarthritis has elements of overdiagnosis, I can tell you. Another word for that is disease mongering, a somewhat older word. Why does it have that particular feature? Well, it is a new entity. As already said, the criteria are rather inclusive. You easily belong to the group of people with non-radiographic, and as a consequence, pharmaceutical industry sees opportunities and promotes drug development in this particular disease, in this field. Physicians at the same time find it very difficult to deal with this new entity because they don't know it very well. They make mistakes, for instance, by diagnosing patients using classification criteria. We have often talked about that, and it is very difficult for the rather uninvolved physicians to make a correct diagnosis of non-radiographic axial SPA, especially when they look at the classification criteria, a well-known problem. And there were indeed already subtle indications of overdiagnosis followed by overtreatment in several cohort studies that we have seen over the years. Is there too much axial spondyloarthritis? Well, there are studies reporting that 25% of patients with chronic back pain have already non-radiographic axial spondyloarthritis. 1 out of 4, which is far, far more than the 5% that we talked about in the early days. There's also studies reporting about non-radiographic populations with extremely low HLA-B27 prevalence, which doesn't make sense. And we have reported on studies with positive MRIs already occurring in healthy individuals even without back pain. So many reasons to assume that there will be a little bit too much axial SPA around in our clinical practices. And this is the time to introduce to you to what I call our inflammation damage axioma. What do I mean by that? In rheumatology, we often talk about inflammation, which will cause subsequently damage. And the inflammatory process, which is a process that occurs at a certain point in time and is chronic, so it goes up and down, it causes signs and symptoms which are due to inflammation. And over time, when time elapses, then it'll lead to a certain outcome. In axial SPA, you could, for instance, think about radiographic progression. What is rather a new type of insight over the last decade or so is that this process of inflammation doesn't only lead to signs and symptoms which are attributable to inflammation, but also over time to what we would call central sensitization, which means that due to the long-term, the chronicity of the inflammatory process, within patients, some sort of secondary fibromyalgia often occurs that has more or less similar signs and symptoms as compared to the inflammatory signs and symptoms that are caused indeed by the chronic inflammatory process. So you may think in terms of inflammation, joint swelling, active MRI and CRP, all features that belong to the inflammatory process or are reflective of that, causing back pain, enthesiopathy and stiffness and fatigue, etc. But you may not realize immediately that those back pain, enthesiopathy, stiffness and fatigue are definitely not very specific for inflammation in itself, but could also be the consequence of that process of central sensitization. And finally, in the end, this will lead to things like function loss, job loss, anxiety and depression, all characteristics of long-term outcome of our inflammatory disease. And if you look at this and understand it, it's very good to realize that what our modern drugs like TNF inhibitors or IL-17 inhibitors in axial spondyloarthritis, what these drugs do is essentially abrogate the inflammatory process so that the inflammation itself cannot cause back pain and enthesiopathy anymore and may have a favorable effect on the long-term outcome. But what it doesn't do is influence that process of central sensitization. So the British talk about the difference between feeling ill or having an illness and being ill or having a disease. So you may feel you have an illness because there is widespread pain, which is refractory to treatment. It's omnipresent. It's chronic back pain in the case of axial spondyloarthritis. Or you are ill, have the disease, you have inflammation on imaging. This is sensitive to treatment. It responds to TNF inhibitors, etc. You may have extra-articular manifestations or bamboo spine or even mortality. And what happens over time in many chronic diseases, especially when we stretch the diagnosis of axial spondyloarthritis a bit, is that this sharp distinction between having an illness and having a disease sort of disappears, and it gets confusing. Essentially, what is the case is that you may have pain and stiffness and many other clinical phenomena which makes a patient going to a doctor and ask our help. And some will have a lot of inflammation and others will not have inflammation. And during the course of the disease, this may change between patients, but also within patients. And as a matter of fact, our current biological drugs, our current expensive drugs, are very good in suppressing inflammation and in suppressing the symptoms that are due to increased inflammation, But if the pain and the stiffness and the fatigue, etc., are not related to inflammation, then in fact, it doesn't work. So we are often talking about remission as being the absence of disease activity, and intuitively with that we mean that there is absence of inflammation. But if there are still many symptoms, that could be in the absence of inflammation, and if that is the case, increasing or intensifying drug treatment doesn't help. So in summary, axial spondyloarthritis, but I think that is the case for most of the inflammatory rheumatological conditions like rheumatoid arthritis or psoriatic arthritis, is often and easily overdiagnosed and therefore also overtreated. An anti-inflammatory medication cannot be expected to work if the symptoms are not caused by inflammation, but rather due to processes like central sensitization, or if that is a better word for you, secondary fibromyalgia. So should we change as rheumatologists? Should we be taught in another way in order to better treat our patients? Well, I would say keep calm and think smart. You know how this works. It shouldn't necessarily be changed a lot, but it makes sense to wait a little while and to observe a patient before you install or change expensive biological or targeted synthetic therapy. Thank you very much.